Hello, everybody. It's a pleasure to be with you. I'm happy to provide a talk about a proof of concept trial in human SCI. My name is Armin Curt. I'm from the Spinal Cord Injury Center at Basel, University of Switzerland. I have no specific conflicts of interest to declare. So we are talking about a proof of concept trial. Many of you know about these conditions of the trials. And in this trial, we will show how we use this proof of concept as an exploratory phase 2 clinical trial. So the preclinical research indicates that the treatment with anti-NOGO antibodies in rodents, but also in non-human primates, has been showing to improve clinical outcomes in these animal models. And based on this, there's this concept that with the treatment of these antibodies, we are enabling the recovery of function based on regeneration of specific pathways. And this is considered to be a potential novel treatment concept in human SCI. So with this background, we initiated the NISCI trial in human patients funded by the EU program. And this was a trial, an investigator-initiated trial across Europe. And this trial has been essentially based on real-world data and is actually making advantage out of inclusive trial protocols. So this is the underlying concept. You need to have neuronal requirements. You need to have preserved tissue bridges. And you also need to have preserved motor neurons to enable the recovery of function. And what you would like to know is if the effects you can see can be attributed to local neural circuits or actually to longitudinal pathways. So with this, the clinical trial is based on the clinical assessments based on the standards of the ISCOS, but also being advanced by neuroimaging and also clinical neurophysiology. And I will try to show you how that worked. So this is a concept again, the anti-NOGO-A antibodies against this NOGO-A protein. And that is the procedure, the treatment, 6 bolus injections within 25 days, at latest 28 days after injury. To run this trial, we have been embarking the data of the NISCI network actually to come up with a prediction models. We want to distinguish outcome cohorts and recovery profiles. And what you also do need is to have an understanding about the frequency of these very specific conditions. With this, we built a prediction tree, and it was based on the prediction being performed at 2 weeks after injury and predicting the outcome at 6 months after injury. And this is what the items of this prediction tree look like. So you have the items of upper extremity motor scores, ASIA grades, and with this prediction tree, you can actually find out where a patient likely ends up at the outcome levels he will achieve. And here you can distinguish patients with ASIA A or B conditions, only ASIA B, or with incomplete spinal cord injuries being called ASIA CD, as you know very well. So it's important to understand that the outcome groups are not by random. You do see very typical recovery profiles within these predefined nodes. And what you also see is that actually in the patients on the left-hand side are way more affected than the patient on the right-hand side. And you see these patients are actually achieving ceiling effects. So you may plan to actually exclude these patients. In addition, what you can see is that the recovery of the upper extremity motor score is also then related to the recovery of the function of the spinal cord independence measure, self-care. So there is a relation between this recovery. This is exemplified here again. So you do see these 3 nodes. You see they start at the very same low level, but they show very different recovery and extent of recovery. And here you see the patient characteristics. All these nodes initially present with a very severe high level of injury and a very severe affection of the motor myotomes in the cervical segments. But this category of patients is incomplete, and you see that this is a very different extent of recovery. And the same is true for these patients that have a somewhat lower level of injury. But again, there's a huge difference in the recovery between the condition of AJA-B or CD. So with this, we define outcome cohorts. We have an understanding of recovery profiles. And looking to the upper limb function in patients with a cervical spinal cord injury is a very essential outcome for these patients. That is what has happened in the clinical trial. 400-something patients were actually assessed for eligibility, and eventually we got 71 patients in the treatment group and 5 patients in the control arm. For safety aspects, you look to all these very typical SIE and AE conditions, and what you find actually is that between the placebo and the verum groups, there's no relevant difference in the amount of AEs observed in these highly vulnerable patients. Just consider these acute cervical injury patients. Here is now the outcome, as you can see it, by the predicted nodes. If you take all the patients, you only have a marginal treatment effect. If you look to these patient nodes with the motor complete conditions, you do see that the outcome is actually there's no treatment effect. You see the majority of patients are AJA, B, or here AJA and B. In the motor incomplete patients, with Cs and Ds, you do see a very different effect. So here you see a significant treatment effect in these nodes. But you also can see, look again, okay, this treatment effect actually is both in the UMS, in the motor scores, but also in the functional readouts. And here again, you can see that the condition of motor complete, independent of the level of lesion, holds true that there is no significant treatment effect. But if you are in an incomplete condition, even with a high or with a lower level of injury, you will have a treatment effect. So this is important that you can actually showcase that the treatment effect is really relevant based on the severeness of the injury, not of the level of injury. And these effects has been then highly significant. But significant is not necessarily irrelevant. So we do know that motor segments within the cervical spine are of relevance. Each segment you can gain will enable you, allow you to perform a better motor function in daily life activities. And this is an example here, a passive tenodesis. As soon as you get the wrist extensors back, you can grasp objects. This is a big difference. So you can categorize the outcomes of the SCIM self-care in different categories, from no hand function, you know this patient very well, up to patients that actually show some intrinsic hand functions, and these are the high levels of independence. If you look to the outcomes then in this patient, you do see this huge difference between the patient in the placebo and in the treatment group in respect of the outcome of intrinsic hand function and high levels of independence. So this is a big difference. So in any of the intention to treat trials, you will have patients who do not either have the full dosing or that have not the full follow-up. So we did a complete case analysis to read to what extent we do see this clinically relevant improvement. And that's what you can see here. You'd see here the relationship between the changes in the UMS delta, the gain of UMS, and the gain in the SCIM self-care between the placebo and the verum group. And you can see that actually the verum group patients almost doubled the percentage of patients achieving this high level of independence. You can do a similar approach with walking. You can categorize the walking abilities in these categories. And most important, for example, walking without walking aids or being totally requiring assistance. And you can then actually, again, look to the percentage of outcomes within the placebo group or the verum group. And you do see that these patients gaining full ability of walking is significantly higher in the verum group. And the amount of patients who are actually totally wheelchair dependent is way lower in this verum group compared to the placebo group. So you have an effect here as well. So what is now defining this condition that the patient can respond? And for this, we look to biomarkers addressing the question of preserved tissue bridges, because you need to have a pathway for your regeneration. And with this, we did MRI studies to develop this concept of tissue bridges, ventral or dorsal tissue bridges, to describe the severity of the damage area. And here you can see, you can distinguish different kinds of lesion, a central lesion, a bordering lesion, or a complete lesion. And these lesion characteristics also relate to the final outcome at here, half a year after injury. So in this predefined nodes, you can see where the level of lesion is. And you can see actually that here in this node, this is a node where the patients have a very low cervical level of injury, but a very severe level of injury. A lot of patients have this complete or bordering conditions. And you can calculate the preserved tissue bridges, and you do see that in these patients with the incomplete, motor incomplete condition, you have significantly higher tissue bridges than in the very severely affected patients. This concept, you then can actually ask, okay, are imaging parameters like tissue bridges perhaps predictive markers? And that's what you can see here. If you have tissue bridges being below 1.5 millimeters or above, you do see that actually here you get a very strong treatment effect. So here you have a Cohen's d of 0.5 compared here to a very minimal and questionable actually treatment effect. So tissue bridges seems to matter. In a different way than tissue bridges, we looked to neurophysiology, looking for longitudinal pathways with tibial SCIs and looking for the preservation of alpha motor neurons within the segments that may be damaged from this lesion. And this is well known in patients with cervical injury. You have an alpha motor neuron damage, and this damage is about 60% of patients, cervical patients, show some extent of alpha motor neuron damage. So it's not only affection of the longitudinal pathways, but also of the segmental motor neurons. And then the question is, does this matter for the outcome? And that's what you see here. In patients with incomplete injury, the better the motor pathways are preserved, the better is the effect of the treatment. So you do have a strong effect of the treatment depending on the preservation of the alpha motor neurons. And this is actually statistically significant, this interaction effect between the preservation of the CMAP severity and the treatment. So thinking about biomarkers in predicting the outcome, you do see here, this is the prediction of the outcome based on clinical means. So this is a distinction between in complete and incomplete patients, and you have a very minimal effect size. If you say, okay, the clinical condition requires that you are motor incomplete, the incomplete patient, then you do see that here is a strong treatment effect. So as soon as the condition from complete changes to incomplete based on clinical means, you will see that here is a treatment effect. If you start and if you look to this treatment effect, you can actually not only look to the significance, but also to the effect size. So is this a clinically relevant treatment effect? If you do the prediction not based on the clinical stratification, but based on electrophysiological prediction, here tibial SCP, you do see that actually in these patients who have a preserved tibial SCP from all comers, you do see a strong treatment effect. And here the effect size is even way bigger. So incompleteness matters, and also the extent of incompleteness matters. So we are coming to the conclusion. In this clinical trial, we can show that we have motor recovery in well-defined, predefined patient conditions. This motor recovery does affect also outcomes of self-care and also, for example, of walking function. And these changes in the self-care outcomes also actually affects the levels of independence. So therefore, there is a good continuation from the motor system changes to function and actually independence levels of patients. So this proof of concept, as being a phase 2 study, has been able to show feasibility and safety. It was actually very applicable. We do understand the outcome measures and the efficacy. And most important, we think we also understand responder. What are the typical and best responders? And the trial design seems to be appropriate. So we think that is one indication here to claim we may have effective regeneration in patients with incomplete spinal cord injury. And the NOGO trial, the NISCI trial, is just one example. So I think it's feasible. We can achieve effective regeneration. And the patients with complete spinal cord injury, here we are still in a very complicated condition. And then the question is, can cell-based or scaffold technology being a way to enable incompleteness that then can be actually used for regeneration across the lesion site? And then there may be actually interaction between both, depending. You can apply a scaffold technology and applying such kind of regeneration therapy. So that's something we have to learn. So all what I have been showing is a huge team challenge. And the team challenge is really also heavily based on the experience with a clinical research network. So this SCI network has been essential actually to deliver and provide all the data you need to have in the planning of such a clinical trial. And also this network enabled to implement the required statistics, adjusted imaging technology, the neurophysiology, and also biosampling of potential biomarkers. And with this, I would thank you for your attention, and it was great being with you. Thank you so much.